Hello everyone. Today we proceed the study about respiratory system. Earlier we learned the inspection and palpation of the respiratory systems, and now I tell you about um, percussion of the respiratory system. Percussion for examination of the chest was first described in 1754 in a little book written in Latin as a new discovery that enables the physician from the percussion of the human thorax to detect the diseases hidden within the chest. At publication, the book was ignored and percussions received little attention until popularized decades later by Laennec and the famous doctor from France, Courvoisier, and by Joseph Skoda from Vienna. These great physicians comment that dullness of percussion perceived like striking the fleshy part of the thigh, indicated fluid or solidification as in pneumonia within the chest. Credit for the observation is generally given to the Austrian physical Leopold Auenbrugger. Tradition has it that Auenbrugger, an innkeeper's son, learned about the percussion by watching his father tap on the wine barrels in his cellar to determine how full they were. It was Auenbrugger who was first used percussion to diagnose diseases of the chest and brought its techniques to the attention of the medical community. These barrels via the Auenbrugger's father was tapped to recognize whether the barrel was full or not. Percussion is one of the most important techniques of physician examination. Percussion of the chest sets the chest wall and underlying tissues into motion, producing audible sound and palpable vibrations. Percussion helps you establish whether the underlying tissues are air-filled, fluid-filled, or solid. Unfortunately, it penetrates only about 5 to 7 centimeters into the chest. However, and therefore will not help you to detect deep-seated lesions. The technique of percussion can be practiced on any surface. As you practice, listen for the changes in the percussion. Notice over the different types of materials or different part of the body. Just a lightly tapping on a container with your hands produces various sounds, so tapping on the chest wall produces sounds based on the amount of air in the lungs. Percussing the anterior chest is most easily done with the patient like supine. The patient should sit when percussing a posterior chest. Place the first part of the middle finger of your non-dominant hand firmly on the patient's skin. Then strike the finger placed on the patient's skin with the end of the middle finger of your dominant hand. Work from the top part of the chest downward, comparing sounds heard on both the right and left side of the chest. Visualize the structures underneath as you proceed. We have next sound when we are tapping of the chest. First, it resonance sound. It is low pitched, hollow sound heard over normal lung tissues. Then, flat or extremely dull sounds are normally heard over the solid areas such as bones. Dull or thud-like sounds are normally heard over dense areas such as the heart or liver. Dullness replaces resonance when fluid or solid tissues replaces air-containing lung tissues, such as occurs with pneumonia, pleural effusion, or tumors. Hypersonant sounds that are louder than lower pitched than resonant sound are normally heard with percussing the chest of children and very thin adults. Hypersonant sound may also be heard when percussing lung hyperinflated with air, such as may occur in patients with COPD or patients having an acute asthmatic status. An area hypersonance on one side of the chest may indicate pneumothorax. And one of the sound is also tympanic sounds. These are hollow, high drum-like sounds. Tympan is normally heard over the stomach, but is not a normal chest sound. Tympanic sound heard over the chest indicate excessive air in the chest, such as may occur with pneumothorax. So by percussion on the chest, we have next sounds. Tympanic sound produced by gastric air bubble, hypersonic in case of emphysema of the lungs. Resonance, we have this sound in healthy lung. Dullness produced by liver, and flatness produced by muscle and thigh. In this picture, you can see where we have met this different sound getting by percussing. The all of them are resonance, if you saw here. Then liver dullness we have in area of the liver. Tympanic sound we have in area of stomach. Cardiac dullness we have in the project of the heart, and flat over muscle and bone give us flat sound here. From posteriorly, of course, the scapula has flat sound here, and the low part of the chest have visceral and liver dullness, and other part are of course resonance sound. Now I show you video where you hear naturally how it seems this sound getting from chest percussion.
This is a normal resonant sound. This is a dull sound. This is a tympanic sound. This is a flat sound.
So you hear it, this sound, how they are hearing it. Now about percussion procedure, how we can do this procedure. Of course, before the patient encounter, keep fingernails clean, groom it and trim it. Wash your hands with soap and water or apply topical disinfectant solution. Warm your hands as able, with warm water or by rubbing and them together before patient contact. The component of the examiner. In theory, percussion can be utilized on any part of the body, but it's clinically most useful in the examination of the chest and abdomen. Here you can see how we are doing the percussion. This finger is called pleximeter, and this finger who is striking is flexor. We place the palm of our left hand on the chest with our fingers slightly separated. We press the middle finger of our left hand firmly against the chest, align it with the underlying grips over the area to be percussed. We strike the center of the middle phalanx of our left middle finger with the tip of our right middle finger using a loose swinging movement of the wrist and not the forearm. Remember this one. This is very important to you. Remove the percussing finger quickly so the note generated is not dampened. You now dampen it, not spreading. Percuss the lung epices by placing the palmar surface of your left middle finger across the anterior border of the trapezius muscle, overlapping the supraclavicular fossa and percussing downwards. Percuss the clavicle directly over the medial third, as percussing the laterally is dull over the shoulder muscles. Visuoplexar or striking finger use the lightest percussion as it produces a clear note. A thick chest wall require a more forceful percussion blow than a thin one. However, if a louder note is needed, apply more pressure with the pleximeter fingers. When percussing the lower posterior chest, stand somewhat to the side rather than directly behind the patient. In these positions, it is easier to place your pleximeter finger more firmly on the chest, making your plexar strike more effective by creating a better percussion note. When comparing two areas, use the same percussion techniques in both areas. Percuss or strike twice in each location and listen for difference in the percussion notes at the two locations. Learn to identify five percussion notes. You can practice four of them on yourself. These notes differ in their basic qualities or sound intensity, pitch, and duration. Train your ear by concentrating on one quality at a time as you percuss first in one location, then in another. Healthy lungs are resonant, while the patient keeps both arms crossed in the front of the chest. Percuss the thorax in symmetric location on each side from the apex to the base. So this method you can practice in home, in any surface, to ask your family members to practice on them. So it's very important uh, to practice this one. There is the affected factors what are affected on the percussion. This is sickness on thoracic wall, calcification of the costal cartilage, hydrothorax containing gas in alveoli, alveolar tension, alveolar elasticity. And of course, every method has contraindication, and so the percussion has this contraindication. Contraindication for percussion is contained in patient when the patient have bleeding disorders, osteoporosis, fractured ribs, and open wounds surgery. What is chronic isthmus? It's a band of resonance representing lung apex. Lateral, it's marked by line joining 2 points, the junction of the medial 2/3 of the clavicle with the lateral 1/3. The junction of the medial 1/3 of the scapular spine with the lateral 2/3. Medially marked by a line between the sternal end of the clavicle and the seventh cervical spine. This area is cranial isthmus you have, and the percussion of the anterior wall of the chest are beginning from here. Percuss from side to side and percuss to side and top to the down as shown in the illustration. Compare one side to the other looking for asymmetry. Note the location and quality of the percussion sound you hear. As needed, percuss the anterior and lateral chest. Again, comparing both sides. The heart normally produces an area of dullness to the left of the sternum from the third of the fifth interspaces in a woman. To enhance percussion, gently display the breast with your left hand while percussing with the right, or ask the patients to move the breast for you. Identify and locate any area with the abnormal percussion note. Dullness represents airway obstruction from inflammation or secretion. Because pleural fluid usually sinks to the lowest part of the pleural space posteriorly in a supine patients, only a very large effusion can be detected anteriorly. The hypersonance of COPD may be obscured dullness over the heart. The dullness of right middle lobe pneumonia typically occurs behind the right breast. Unless you displace the breast, you may miss the abnormal percussion node. Identify the locate an area with an abnormal percussion node. Percus for liver dullness here and gastric tympani with your pleximeter finger above and parallel to the expected upper border of liver dullness. Percus in progressive steps downward the right midclavicular line. Identify the upper border of the liver dullness. Later, during the abdominal examination, you will use these methods to estimate the size of the liver. As you percus down the chest on the left, the resonance of normal lung usually changes to the tympani of the gastric ear bubble. The hyperinflated lung of COPD often displaces the upper border of the liver downward and lowers the level of diaphragmatic dullness posteriorly. Now I show you video how to do the percussion of the anterior wall of chest, beginning from isthmus and go down and comparatively.
Really, the third step in the examination of the anterior chest is percussion. Let's know the technique of percussion. The technique of percussion in the following way. First of all, find an intercostal space, and then put your middle finger, which is the pleximeter, and then strike the middle phalanx in the following way. Okay, this is about the technique of percussion. Really, in the examination of the anterior chest, first of all, we have to percuss both lung apices. As we have learned, the left apex or right apex extend about 2 to 4 centimeter from the inner third of the clavicle. So we have to start here, put your middle finger just like this, and then percuss, compare it with the contralateral side. In the clavicle, we have an exception here, that the percussion should be performed without pleximeter in the following manner. And then we have to percuss up to the sixth rib in the following manner also. And then the axilla, we will choose an upper axillary area, compare it with the contralateral side, and lower axillary point. The question here is why we choose the sixth rib anterior and we choose the eighth rib in the axillary area. These are the borders or lower borders of the lungs. In the percussion, you have to know that the percussion notes are or should be resonant in nature all over the chest, except the hepatic and the cardiac dullness. The liver dullness usually start from the fifth intercostal space downward. The examiner or the candidate should know about the type of the percussion note, whether it is resonant, which is normal, or hyper-resonant, abnormal, and may occur in, for example, in pneumothorax. And we have to know other abnormality in the tone in case of dullness. For example, an underlying cause should elicit an underlying cause of fibrosis, consolidation, collapse. And if we have stony dullness percussion note, stony dullness percussion note may occur in patient with pleural effusion. All these issues and scope are about the percussion of the chest.
So you notice that everywhere was resonant sound except of the area where there was liver, there was dullness sound, and on the left there was tympanic sound. There is gastric bubbles here, and here of the gastric. Okay, now percussion of the posterior wall. Percuss from side to side again, top to bottom, using the pattern. Omit the areas covered by the scapule because there is no sense to percuss here. There is only flatness sound here. Compare one side to other side looking for asymmetry. Note the location and quality of the percussion sounds you hear. Find the level of the diaphragmatic dullness of both sides, approximately here. Percuss one side of the chest and then the other of at each level in ladder-like. Oh, what this means, ladder-like pattern as shown in figure. Omit the areas over the scapule. The thickness of muscle and bone alters the percussion nodes over the lungs. We identify and locate the area and the quality of abnormal percussion node. Dullness replaces resonance when fluid or solid tissues replaces air-containing lung or occupies the pleural space beneath your percussing fingers. Examples include lobar pneumonia, in which the alveoli are filled with fluid and blood cells, and pleural accumulation of serous fluid in case of pleural effusion, blood in case of hemothorax, pus in case of emphysema, fibrosed tissues or tumor. Dullness make pneumonic and pleural effusion 3 to 4 times more likely, respectively. Generalized hypersonance is common over the hyperinflated lungs of COPD or asthma. Unilateral hyperresonance suggests a large pneumothorax or an air fluid bulla. Except the comparative percussion of the lungs. The second method is a topographic percussion. By this method, we determine the border of the lung, whether they are increased or increased. It depends on different diseases. For that is rule 579 rule. The upper border of liver dullness is defined by fifth intercostal space in the midclavicular line, seventh intercostal space in the midaxillary line, ninth intercostal space in the scapular line. Note that ninth intercostal space is located approximately at the inferior border of the scapule. Hypersonance, the continuous below these boundaries can be suggestive of hyperinflation. Another part we must to tell you about is cardiac dullness. Because in the place where the cardia, the heart, there we have not resonant sound, but we have little dull sounds. Be able to outline the area of absolute cardiac dullness, a fist seized area just to the left of the sternum. If it's not there, it suggests emphysema. So in case of emphysema, between the skin and the heart is air. I tell you about this area. This is the area of cardiac dullness. Here, instead of resonant sound, we have a little dull sound, and we not see it as pathological sound, but very normal sound. Now about Traube space. what space it is. It's near the gastric surface making by superiorly left six rib inferiorly, left costal margin, laterally anterior axillary line. Usually, Traube space is hyperresonance due to the location of the gastric bubble. However, losses hypersonance can be seen in the following condition. Left pleural effusion, however, not in left lower loop pneumonial without effusion, as it's effusion that falls into the costophrenic recesses there is above the gastric bubble. Splenomegaly, less reliable compared castal signs, and very full colon. And so we can discuss if the patient recently was eaten, stomach when the stomach is fully. Here you can see the Traube triangle, Traube place, where we have a tympanic sound. So as we say, the superior border is 6 ribs, the inferior border is costal margin, and lateral border is anterior axillar line. So by topographic percussion, the border of the lung are next. Apex of lung is chronic isthmus, 5 centimeter in width. Narrow, it is narrow width when we have tuberculosis, fibrosis. It became wider when we have emphysema. Yes, in anterior border, the border is absolute cardiac dullness, and lower border is 6, 8, 10 intercostal space in medioclavicular line, mediaxillary line, scapular line, respectively, and downward. It is became downwarded in case of emphysema and became upwarded in case of atelectasis. Intra-abdominal pressure increases. Now about diaphragmatic excursion or chest excursion. Identify the descent of the diaphragm or diaphragmatic excursion. First, determine the level of diaphragmatic dullness during quiet respiration, holding the fleximeter finger above the parallel to the expected level of dullness. Percuss downward in progressive steps until dullness clearly replaces resonance. Confirm this level of change of percussing downward from adjacent areas both medially and laterally. These techniques tend to overestimate actual movement of the diaphragm. An abnormally high level suggests a pleural effusion or an elevated hemidiaphragms from atelectasis or phrenic nerve paralysis. Short level means COPD. Percuss along the scapular line on the side until the level of the diaphragmatic dullness. Ask the patient to inspire deeply and hold this breath. I am repeating now this one. Proceed to percuss down from the marked point to determine the diaphragmatic excursion in deep inspiration. Repeat the procedure on the opposite side. Measure the distance between the upper-lower position points in centimeters on each side. Excursion is normally 3-5 centimeters bilateral and symmetrically. So this area are decreased when we have emphysema, atelectasis, fibrosis, pulmoedema, pneumonia, and sometimes it's impossible to detect when we have pleural adhesion, massive hydrothorax, pneumothorax, diaphragmatic paralysis. In these cases, the lung not moving up to down. Also, except the chest excursion, we make tidal percussion. Tidal percussion. It is used to differentiate it supradiaphragmatic from infradiaphragmatic dullness to find out where the disorder is. While the patient seated finds the upper level of dullness, ask the patient to take deep inspiration and to hold it, then percuss again. If the note becomes resonant, to is changed by intra-diaphragmatic cause. If it's no change of the note, it means the reason was supradiaphragmatic cause as pleural effusion. Now let we see video how we doing chest or diaphragmatic expansion.
I'm now going to percuss down your back for diaphragmatic excursion. What I'm going to want you to do is to take a deep breath in, let it out, and then hold it. I will do some percussion. Then I will need you to take another deep breath in and hold it, and I will percuss some more. So let's start now. Take a deep breath in, let it out, and hold it. Now take a deep breath in and hold it. And you can let it out. And as I measure that, it comes to be about 5 centimeters, which is an expected amount of diaphragmatic excursion.
Okay. This is a table characteristic of sound what we have in case of percussions. Maybe timpani sounds, it characterized by intensity of sound, pitch of sound. Yes, by intensity it's loud sound, by pitch it's high pitched, by length it's moderate, quality drum-like, and it occur in buffet of the cheek, gastric bubbles. Dullness, what is very important that you must know about it. It is medium intensity, medium pitch, moderate length, thud-like by quality, and we have when we have diaphragm and pleural effusion, and so others. So in chest we have sound what are connected with diseases. Resonance sound, it's normal sound, and no diseases are connected with it. Hyperresonance sound are connected with emphysema. Timpani sound are connected with if they are in the chest cavity or pneumothorax. Dullness sound are connected with hydrothorax and atelectasis. And flatness is connected with massive hydrothorax and massive atelectasis. So, as you understand, we have a normal sound and abnormal sound while we are percussing the chest. And as you understand, the normal sound are resonant sound. And sometimes a slight dullness in some areas, upper right back due to the sickness of muscles and skeletons. Abnormal sound are the first, dullness or flatness, decreased containing gases in alveoli. We have this in case of pneumonia, atelectasis, tuberculosis, pulmoembolism, pulmoedema, and pulmofibrosis. The next abnormal sound is no, excuse me, we are continuing the dullness. We have dullness in case of tumor, in hydrated pneumocyst, non-liquefied lung abscess, and also in case of hydrothorax and in case of pleural sickness. Another abnormal sound is hypersonance. This is we have in case of emphysema, when the lung is full of air. And more than hypersonus sound is tympanic sound. We have in case of pneumothorax, when the air go to the chest cavity from outside, and when inside the thorax, sometimes we occurred large cavity during the tuberculosis, lung abscesses, and lung cyst. And amphoropony, we have in case of large and shallow cavity with smooth wall and with tension pneumothorax. What is tension pneumothorax? We will learn later. Now it's more difficult for you, but I want anyway to say you. We have here hydrothorax. In this area, the lungs are full with fluid here. So instead of the resonant sound, now we have dull sound, yes. And here in place of resonant sound, we have tympanic sound. And in this case, it is made by rentgenography. We have Garland triangle area, what is tympanic dullness, Damoise line, it is Damoise curve, and Groho triangle area. What they means? Damoise line is from French doctor Damoise, is an arcuate line of the upper boundary of percussion, blunting characteristics of exudative pleurisy. The Garland triangle is a triangle space of unsharp percussion dullness with a tympanic hue between the spine and the ascending part of the Damoise line, characteristic of exudative pleurisy with sufficient volume or pleural effusion. And the triangle of Prochorachus is a triangle space of percussion dullness on the healthy side along the spine arising from massive exudative pleurisy. This you will learn in later classes when you will have internal diseases. I'd like you to show you the video how to do percussion.
Respiratory system. Introduction. The setting for the chest examination must be environmentally comfortable for both the clinician and the patient. The examiner greets the patient, asks about the symptoms that initiated the visit, and begins physical inspection, noting body position, assessing degree of comfort, inspecting and assessing the patient before continuing into an in-depth examination. Technique. The pulmonary examination consists of inspection, palpation, percussion, and auscultation. The purpose of percussion is to determine if the area under the percussed finger is air-filled, that is, sounding resonant like a drum, fluid-filled, that is a dull sound, or solid, a flat sound. To make this interpretation, it is important not only to listen for the sound produced, but also to feel the intensity and frequency of vibrations produced by this maneuver. What to observe during percussion? Dull note, resonant note, diaphragmatic excursion. Procedure. Introduce yourself and confirm the patient's identity. Explain what is going to take place and ask for consent. Make sure your palm is warm before percussing any patient. Ask the patient to lie supine. Place the left middle finger, fleximeter finger, on the area to be percussed. The back of its middle phalanx is then struck with the tip of...
Now look again this, how not to do the percussion. Not swinging by forearm, but a swing by wrist.
Right middle finger,
It's
percussing finger.
abnormal.
Make sure that the percussive movement originates at the wrist and not at the
Wrong
elbow.
technique.
Percuss over each intercostal space on the anterior, lateral, and posterior chest wall in such a way that the long axis of the percussed finger is roughly parallel to the ribs. Compare one side to the other. When percussing over the chest and back, move back and forth across the thorax in a systematic fashion, comparing one side of the body to the other. There are two sounds to listen for while percussing: resonant sound, dull sound. Resonant sounds will be heard during percussion over the lungs till you reach the diaphragm. If you hear dullness over the lungs during percussion, this could possibly suspect the presence of a mass or consolidation. Percussion. Ask the
Now she
patient
will
to sit upright
tell
with the back
you
exposed
about
and ask to take a deep
chest
breath and hold
excursion.
it. Then begin percussing at the base of the right scapula and move downward towards the patient's diaphragm. When you detect a change from resonance to dullness, you will have found your first anatomic landmark. Tell your patient to breathe and place a mark at this site before continuing to the next step. Now, ask your patient to exhale as much as possible and hold it. This time, begin percussing at your first landmark and move upward on the posterior thorax towards the scapula. When you notice a change from dullness to resonance, you will have found the second landmark. Place a mark at this site. Repeat this technique on the other side of the patient's posterior thorax so that you can compare measurements on the right and left sides. Once you obtain your two landmarks, measure the distance from one line to the other to determine diaphragmatic excursion. Normal excursion distance is 3 to 5 centimeters. Physical findings must be interpreted in light of all previously collected data. The general scheme is to develop a postulate and test it with further history, additional observation.
So it was percussion of the chest and respiratory system. So next time we will have auscultation of the respiratory system. Thank you.